Hi, good morning. My son has been part of all of your studies, and he is 15 months post-transplant. And I heard, well, I was told when I was out, you said that y'all took samples of the livers, and I was wondering if that was like a standard practice for all of your patients, and if there's information on individuals. The second question I have is, he is ASA, and so his liver enzymes were always affected, always elevated. After the transplant, his ALT or AS, one of them, is still trending upward. And so I was wondering if you looked into, because the ASA is all over his body, if that is the reason why the enzymes are elevated um, even after the transplant, and if you have done any follow-up studies that we could participate in, like post-transplant for patients with ASA.
I'll go ahead and take that question. Thank you for that question. So to answer the first part of it about what is standard practice at institutions after a transplant. So after a transplant, it's standard at most institutions for every patient, no matter what the reason, to collect tissue and look at it under the microscope and then give a clinical report that goes in the chart to tell the doctors what they saw. So that's in the charts of all the patients, and certainly can talk to your providers about that. They can share a copy with you and go over it with you. And so basically what we did was collect that information, had a pathologist look at it again, make sure the same person looked at all the tissues again, but really it was reflecting what was in and already done clinically. So that's the answer to the first question. The second question is a little more complicated because, and there are other folks here who probably can even answer this better than me, but there's a lot of reasons why enzymes can go up after transplant. I certainly think your question's a very interesting one. It's not one that we've been exploring, but certainly one we can keep our eye on to see if we start to see patterns. But it does get complicated because there are other reasons that can happen after a transplant too.
Well, if it's not related to rejection, because all the other markers are normal, just one of them is just like keeps going up.
Yeah, it's an interesting observation that we'll go and look into more because it's not something we've explored yet. But thank you for asking that. I think it helps us learn when we hear about these anecdotes.
Thank you.
Yeah, thank you. Hi, my name is Nikki Weinlein, and I have a daughter with ASA, and I have a question about the FNIR study. The DTI comparison information was interesting to me after the study last year that showed the basal ganglia changes and the motor stuff in ASA. And I wondered if your study was going to look at not just the executive function, but also kind of the motor changes in ASA specifically in those who do and don't have seizure activity.
Okay, yeah, that's an interesting question. So, for our multimodal imaging study, we do have patients that are not just OTC and arginase deficiency. We just don't have many. But the plan is, given the information we found with the recovery from hyperammonemia and OTC, and then also some subsequent information that was found in the mouse model of arginase deficiency, that even the parents may have some decreased fiber tracts, we've decided that the next step we want to do is more of a motor assessment across the board and working to develop like a gait lab, like where they walk, and we can do those measures. We don't have it yet, but that's something that we're thinking about in the future. So stay tuned for that. Yeah, where do you live?
Here.
Oh, okay. Okay.
Dr. Burrage is laughing.
Okay, thanks.
You can have me anytime you want. My second question is, in that study, what is your control for people who have executive dysfunction but are not affected by a metabolic disorder?
So that's a great question. So we have normal controls, and then we have other metabolic disease controls that don't have executive function. And then we have patients with just like ADHD who don't have metabolic disorders, who have executive dysfunction. So because it's not enough to just compare against a normal group, we need other populations that have other diseases or just have like a just executive dysfunction.
Perfect. Thank you very much.
Hi, thank you for these three very excellent talks. My name is Anna Wexler. I have a 3.5-year-old daughter with OTC. So I have two related questions. So one, as the UCD patient population is getting older, how is the UCD consortium thinking about emerging issues that we have to think about, for aging populations? So sort of what are the issues that are you guys are thinking about, and also how are you identifying those issues? Are you waiting for them to sort of come up from the patient population? Are you looking to sort of, I don't know, analogous cases or other areas, because there's so many other diseases where now, we didn't have to think about disorders in aging populations, and now we do.
So I'll start off, then I'm going to hand it to Sandesh. So, that was actually one of the goals of this cycle of funding, was to look at the true longitudinal into adulthood, because we recognize that outcomes have improved, and thankfully we do have that, very interesting situation where patients are aging, and what comorbidities they may have that are either due to the disease that we wouldn't have seen earlier because we didn't have such great outcomes, or the medications that they're on long-term, or protein restriction long-term, and or other comorbidities of adulthood that, you could still be at risk to have other conditions that may not be related. So I'm just going to take it from the executive function and the neurologic aspects. So, looking for real world manifestations of the executive function. So that's why we decided to do the driving as a multitasking. We may look at other things as well, following patients yearly to see if there's any decline in either cognition or motor function. And neuropathy is something that we had put into our original grant. So this is problems with the nerves and loss of sensation, or sensations that shouldn't be there, like a burning or a tingling. Looking at that, whether that could be part of the disease, part of the protein restriction, and or part of the medications. But I'll let Sandesh talk about just in general, since he's an internist.
So let me try to break this down into 2 or 3 ways we can address this. So the first one, as Dr. Gropman pointed out, was as the population now ages, what is the interaction between the urea cycle disorder and the general sort of disorders that occur with age? One of the things that we are interested in is the high blood pressure in the individuals with argininosuccinic aciduria. We have noted that there may be an overrepresentation of this. What happens when people age and they basically are prone to hypertension? Second part, this dovetails into what the previous individual asked about the motor abnormalities. There are some mouse data to suggest that, again, loss of ASL in the brain may give a higher risk of developing motor issues, especially as they age. We have looked at some of these from the natural history study. We have not been able to pinpoint a signal, either because of the data that we don't have, or because we don't have so many people who've aged out past 40 or 50 years who are actively enrolled. So to your question, from the interaction of UCD and the common disorders, that's a very interesting and relevant one. I don't think we have answers to that. The second part is the operational aspect. As people transition out of pediatric into the adult care, pediatric hospitals are a lot better at coordinating care. They're under one organization. All specialists are available. All bets are off when you enter adult medicine. So how do we transition care? And this is an important part with NUCDF as well. It's an interesting thing they want to do. How do we sort of democratize care. Not everybody is going to be able to reach to an Andrea Gropman or Lindsay Burrage. So if they're out in the community, how do we increase the caregiving? Tele-Echo program from the NUCDF is trying to do that, which will feature a transition of care as well. So those are the things we're looking into, but what do you think we should look into that we haven't? And I know that there are adults here within the, I saw Ms. McCracken say, yep, so she's got a couple of things to say. What do you think we should be looking into?
Probably menopause for women. Memory issues as we age. I mean, normal people have memory loss, and I already have enough memory loss, but I have notes everywhere. And I believe advocacy, like having someone else who is functioning normal, like in your family, around you as you age, because I think that's really important to have somebody else there. Not to be alone, because I feel like if you're alone, just the worst can happen.
One more thing I left out was an important question that Dr. Sue Berry, who's in the audience, can speak to, is looking at women with OTC deficiency and pregnancy and what the outcomes actually are. And yesterday for the UCDC meeting, she presented from some beautiful data from the analyses that she has done. So that's one more. I know that you were not referring to that population as aging, but the older adult population is what I was referring to.
So I can briefly talk about the menopause. So we have a paper that's been accepted for publication. This is work of Dr. Jerry Bedoyan, who used to be at our Cleveland site. He had a pilot study to look at carrier females and whether those who are asymptomatic could become symptomatic. And so he did find some changes around the time of menopause where individuals who weren't symptomatic or maybe were but had milder manifestations that weren't really coming to medical attention started to have more overt symptoms. However, if you looked at those individuals back into their adolescent years, there were probably some behaviors and mental health issues like anxiety that just weren't rising to the surface enough to be acted on. So more to come with that.
Yeah, thank you. We've only got about 5 more minutes left for questions. If you want to finish your thought.
I think she had one comment.
I was just going to comment, that's one of the reasons we did the liver study, was because we recognize that folks as they get older may be at risk for liver disease in the general population from things like overweight, obesity, alcohol use, et cetera. And so we wanted to look at that combination as adulthood, as folks transition to adulthood and they have a UCD in their liver, how do all those factors come to play?
Good morning. My name is Teresa Brown, and I have a grandson and a daughter with OTC deficiency. My first question is, can your MRI imaging help someone that had a later onset diagnosis at age of 30 tell if there's been any damage or any future concerns that she might look after?
Yeah, absolutely. A lot of the first patients in our study were older with later onset, including males with late onset. So, it allows us to look back in time and see things that might have happened. And also from the biochemical standpoint, I think having a low myo-inositol is a concerning biomarker for us. So yeah, absolutely. Any age we can see if there's been any changes.
Okay, my second question was, I think I forgot. I have so many. One general question is, with the OTC deficiency and the low protein, which means majority of their consumption is carbs, being young kids in a school environment, it can be looked at as being hyper. Has there been any studies that seen where kids might have been diagnosed with ADHD versus with the OTC?
So, a lot of the younger children may carry a diagnosis of ADHD, but ADHD is part of this executive dysfunction. Could they have been missed in terms of their comorbid diagnosis of OTC? Sure. If they didn't have overt manifestations, we may just see, or overt other manifestations, you might just see the ADHD as coming to the top. And we see that with other metabolic disorders as well, as where a behavior change or a cognitive change may be the first symptom, but they may not have full-blown, vomiting or lethargy or other symptoms. So it's certainly possible that someone could not be picked up and just be recognized in terms of what that cognitive manifestation is.
Have there been an increase in diabetes in these patients?
I actually do not know the data for that.
Okay. All right. Thank you so much for your time.
Yeah, thank you for your questions. Yeah, I think new research raises new questions. The more we learn, the more we need to know. And one of the things that Teresa and I want to do with NUCDF is start a research patient advisory committee where we can get a broader range of patients, all 8 diagnoses, newly diagnosed, have been diagnosed for a long time, together to ask these questions and help us communicate these with the researchers. And I think, any final words you want to say?
Thanks for all your questions. Keep them coming, because that's what drives our research.
Thanks to our panel.